Yeah, good evening, everybody. Till the time everybody joins, today I've just posted a video on Friendos group. You can have a look at what is Ran Panchami celebration in Indore. It's wonderful and one of its kind in the world. You can have a look and then then you can start. Okay, all the best. Bye.
Yes, sir.
Recording in progress. Thank you.
Bashir Chepo. You're waiting for Rakesh Sai, sir. Sir is not lifting. So, sir, maybe sir will join in the middle. Dr. Lavanya.
Hello, sir. Good evening, sir.
Go ahead.
Sir, good evening, everyone. Respected seniors and my dear colleagues. So today we will be discussing about interesting cases of endocrine hypertension. So today's I would like to thank Dr. Rakesh Sai sir, Dr. Suresh sir, and Nitin Kapoor sir for joining. And I would like to hand over the my stage to Dr. Ashwini from Vizag.
Yeah. Thank you so much, ma'am. Thank you. Good evening, everyone. So it's my great pleasure to welcome you all today for today's insightful webinar organized by Endocrine Society of Andhra Pradesh. So we are thrilled to have such a distinguished group of people and experts who gathered here today for engaging discussion, which is complex and critically important for us. That is endocrine hypertension. Jerome W. Kahn in 1954 in his presidential address probably first time told us about primary hyperaldosteronism, after which the renin-aldosterone axis has come into play and explained to us many insights about how hypertension can be treated and the role of hormones in such therapy. So today we have young endos who will be discussing two cases on endocrine hypertension, and we have experts from all over India to provide their valuable insights and discuss the modern treatments for endocrine hypertension. Hope this session helps us to gain a deeper understanding of these conditions and also helps us to manage this condition. I encourage all of you to actively participate and share your thoughts on the cases. And this is a wonderful opportunity for all of us. Once again, I thank all of you for joining us, and I'm looking forward for an enriching and informative session. So, I now welcome Dr. Nitin Kapoor sir, Professor of Endocrinology at CMC Vellore and Executive Committee Member of the Governing Council of Endocrine Society of India. Welcome. Thank you for accepting our invite. I also invite Suresh sir, Professor and Head of the Department of Endocrinology at AIIMS Mangalgiri, for accepting the invitation. And I also welcome our guest of honor, Professor Rakesh Sai sir, currently of Osmania General Hospital. I now request Nitin Kapoor sir to talk a few words.
Thank you for that. And first of all, congratulations for choosing such a great topic and starting this very important series and making it very clinical and case-based. I think endocrine hypertension is something that requires a lot of awareness. A lot of patients still, unfortunately, are missed in our clinical practice. And the best part of identifying these patients is that this is a potentially curable disease, unlike many other types of hypertension. So I'm really looking forward to this session. And thank you so much for inviting me.
Yeah, thank you so much, sir. I now request Suresh sir also to have a few words.
No, anyway, it's a very good topic to have a discussion on, but because most of the people are not even evaluated for endocrine hypertension, we miss those cases, and as a result, patient suffers from devastating consequences. So we should know when to search for endocrine hypertension and how to go about it. That's a nice topic. Thank you.
Yes, sir. Thank you. So we'll start the session. So I now invite Dr. Golla Kiran Kumar sir for his case presentation. Dr. Kiran Kumar Golla completed his BM endocrinology from AIIMS in July 2022 Currently, he is practicing at the Center for Endocrinology and Diabetes, Obesity and Thyroid at Visakhapatnam. Welcome, sir. Over to you for the case presentation.
Thank you, Dr. Ashwin, for your kind introduction. Good evening, everyone, my colleagues and my seniors and professors. Thank you for giving me this opportunity. So today I'd like to discuss few cases of endocrine hypertension. Sharing the slides. Are the slides visible?
Yeah, yes, sir, they're visible.
Yes.
But you should keep them full screen. Right?
Yeah. Full screen done. It's visible, right?
Yeah.
Perfect.
Okay. So let's keep the discussion a little bit interactive. So this is one case of 39-year-old male with history of hypertension since last 8 years. Starting the control was not bad. It was control was good, but since last 2 years there is a history of sudden onset of breathlessness, chest heaviness, and hypokalemia, and it was diagnosed with accelerated hypertension with 190 by 103 mmHg, and patient was treated in emergency at that time, and again patient did not follow, and he was discharged. And again 6 months ago, again he presented with severe headache with BP of 220 by 110 around, and current BP medications for patient was on amlodipine 10 mg per day, telmisartan 80 mg, clothianidone 12 mg, and prazosin 5 mg per day. So with these 4 drugs, he is controlled, and no family history of any hypertension or cardiovascular disease, no other as such any comorbidities are present in the patient, and because of young hypertension, and also because of needing more 4 drugs for the control, he was evaluated for the secondary causes of hypertension. And in the history wise, mild symptoms of hypokalemia like cramps, etc., also present. And these are the conditions in which we may suspect the secondary hypertension, like patient younger than 40 with hypertension grade 2, grade 3, sudden onset of hypertension, acute version of BP control with previously well-controlled treatment, like in our case, resistant hypertension, hypertension emergencies, grade 3 malgrade hypertension, and clinical or biochemical features history of few endocrine causes like VO have its features, other hypokalemic features, and renovascular disease, and many cases we miss sleep apnea. Many patients have, because of obstructive sleep apnea, we have hypertension, diabetes, which need to be addressed in the patients, and severe hypertension pregnancy also we should suspect. So in previous Williams in 1337, these are all in 13th edition of Williams. These are the conditions which were considered to required for the screening of primary hyperaldosteronism. But in the latest edition, they changed it to all patients with hypertension should be screened at least once in their lifetime. About because of its increased prevalence, and because of many cases are not diagnosed, and even cutoffs also previously used to follow ARR ratio, but now it's better to interpret it individually with aldosterone more than 10 and suppressed renin, it may be activity or DRC. Coming back to our case, hemoglobin in our case is 12.1, and CVC parameters are fine. No, ABG also is okay. No gross metabolic outputs or anything. And electrolytes later on, history of hypokalemia is present, but again, repeat parameters were normal. There is mild pre-diabetes is present, and thyroid profile is normal, and calcium is normal. So few routine secondary hypertension causes are ruled out, and also there is no renal artery stenosis in renal Doppler, and 2D echo. There are signs of left ventricular hypertrophy, and also fundus. There are few changes of hypertension retinopathy, which indicates that patient's hypertension is not in very good control. So then, aldosterone and dietary contest was done, and which showed aldo high and with the suppressed DRC, and at that time potassium was 4.1. So next, when we see the screening test is positive, we next need to proceed to confirmatory test. In young patients with aldo more than 20 with hypokalemia, we can skip the confirmatory test. But in this case, confirmatory saline suppression test was done, came to be positive. So next, CCT abdomen was done, and internal mass of 1.7 centimeters were found in the left side, which is suspecting to be adenoma. But as a patient is 39 years old, so next adrenal venous sampling is planned, and these are the cutoffs which we usually follow for adrenal venous sampling. Selective index for the cannulation, success for cannulation. We usually do with stage simulation, we require more than 5, and lateral index more than 4. We follow. Less than 3 is bilateral, and in between is intermediate. And other ratios I will discuss in the next slides. And this is the adrenal venous sampling criteria for this patient data. So in this we can see that the right there is left adrenal vein is not cannulated. Sir. So right adrenal could cannulate, but it could not cannulate the left adrenal vein. And when compared to so because in such cases we can use the contralateral suppression ratio. So the contralateral suppression ratio is to avoid the dilutional effect. We usually use cortisol to divide, and for all understand values, and contralateral is a non-dominant adrenal vein divided by peripheral, and if it is less than 1, it is suppressed, and if it is less than 0.5, it strongly indicates that opposite side is pathological. So in this case, contralateral suppression we could get, but lateralization we could not get because of in cannulation we could not do. So with that data, surgery was done because CT also suggesting left-sided. So left adrenal adnectomy done, and clinical and biochemical revision later on. So if we see in that in that workup, did we miss anything in this work? So in in all recent guidelines, it was found that in many cases PHA there are also metabolic complications like diabetes, other metabolic complications are seen. So so co-secretion of cortisol is also is found in many cases. So in selected patients, ONDST and HS also should be done. And so when should in which cases of adrenal adenoma cons that causal axis evaluation should be done are mainly large tumors. Usually, for causal regression, we need bigger size of the tumor. So, because if more size of tumor is more than 1.5, we should also evaluate co-secretion of cortisol. Being in a case has 1.7 size, DHS should also be done. In our case, HCS and ONDST, which are suppressed. So there is no associated co-secretion of cortisol. So suppose if the same case ONDST positive and if co-secretion of cortisol is also present, then how to manage the case? So should we start the anti-metallocorticoid receptor antagonist therapy, or should we do AVS, or can we proceed to surgery directly of left adrenal adenoma, or should we do bilateral adenectomy? So if generally when ONDST is positive, we need to see is it ipsilateral one side lesion is present or bilateral. Because we are having only single side lesion. So in the size of the lesion is more than 1.5, and ONDST is not suppressed. So it indicates that the size of the lesion is on the same side. So AVS is not mandated in such cases. We can directly go ahead with the surgery, assuming that other CT is they have not having any nodular adenoma. In a similar situation, suppose patient is having bilateral adenoma. In such cases, bilateral lesion, then again if ONDST, if we found co-secretion of cortisol, then how to manage? In the same options for this question also. So in cases, we have to do AVS, and in such cases, we usually, because cortisol is we use as a divide to neutralize the dilution factor, but in these cases, because cortisol is secreting from only one side, so we cannot use that for dividing. So in such cases, we may use other androgens like androstenedione or DHA or DHAs, and these are the cutoffs found in few studies. In few cases, we can follow these cutoffs. And if bilateral lesions are present, cons is present, and next co-secretion of cortisol is present. Next question is the single lesion secreting both cortisol and aldosterone, another lesion, is it incidentaloma, or one lesion is secreting cortisol and another lesion secreting aldosterone? Because management plan is different for both. How to diagnose that part? So in such cases, we can, there is a study from Mayo Clinic. They have seen that annual venous sampling for lateral lesion of cortisol hypersecretion patient with bilateral adenomas. So they have cortisol lateral ratio more than 2.3 will indicate unilateral cortisol hypersecretion, and less than 2 indicates bilateral cortical secretion. So we can see that in this is a case. Both bilateral lesions are present. Right side around 2 centimeters, left side around 5 centimeters lesion present. So indeed, the right CLR 2.5 km. So secretion is from right cortisol. So in such cases, if patient is having both secretion from different different adenomas have different secretion, we usually try to address first cortisol secretion, because it's easy to manage with medical therapy in hyperaldosteronism rather than hypercortisolemia. So first, hypercortisolemia should be addressed with the surgery, and next plan can be medical management can be done. And in the recent, there are in areas we can even go up to still not only anti-adrenal. Uh, we can even go into inside branches of adrenal and we can see from which gland part of the gland. In few centers it's being done. If we can able to do that, we can do adrenal sparing adenoma resection also in such cases. And this is another case, bilateral lesions is present and CLR is 1.3. So bilateral lesions are present in this case, cortical secretion of bilateral. So it's already discussed. Um, so this is another short case. This is little bit tricky case. 21-year-old male with BMI of 26.5. Symptoms of cramp and headache. Visited to general physician, and he's having these symptoms since last 6 months. And hypertension diagnosed, mild hypertension with 140 to 150 systolic and diastolic 95, 4 months back. So patient is on amlodipine 5 mg PD and no history of CKD and no history of paroxysm or episodic palpitation. So patient is under physician, and because of young hypertension, he was evaluated, and his routine CBC and normal, and EBG also normal. All routine parameters are normal. Even thyroid profile is normal. So renal Doppler, no renal artery stenosis, and CT abdomen also was done, and no adrenal mass. So 2D echo is no LVH and fundus is normal. So next investigation is PRA is done, and PRA found to be suppressed. So we suspected maybe hyperaldosteronism will be the suspect for next game. But Aldo came to be lower side. It was not high because we need Aldo more than 10 to say primary hyperaldosteronism, and there is no hypokalemia or no hyperkalemia. And cortisol is normal, and ONDC is suppressed, and ACT is also normal, and it's not raised. So in such cases, in many cases in day-to-day practice, we see low renin hypertension. So if in cases of low renin, anyhow high aldo means we'll go PHA, and if low renin and low normal aldo with high potassium, we should suspect Gordon syndrome, that is pseudo hypoaldosteronism type 2, and low renin, low aldo. These are the many. Um, these are many diseases. We have genetic like little apparent medullary access, CH, mRNA activating mutation, and primary glucocorticoid cortisol resistance. And these are the few acquired causes, and licorice and some grape juice abuse also can cause. NSH, heparin, and ectopic acetosis in dog secreting tumors or low renin essential hypertension is also one entity seen in few cases. So, because in our case, among these low renin, low aldo, these are the few possibilities we because cortisol is ONDC suppressed that axis we are not suspecting. CH, little syndrome, AME or dog tumors. But uh, patient is not having any family history and not having hypertension since childhood. So doc was done and it came to be not elevated. So when doc is not elevated, CH is ruled out, doc tumors also ruled out. So these are the little syndrome and AME were the possibilities we were thinking. Actually, patient were referred to endocrinologist at the stage of low PRA. So So next, what's next? So because patient is not fitting into any of the case, any of these conditions, and there is no strong suspicion towards MHR littles because of no family history and because of cause concern. Again, case is revived. Again, case history again from starting we had taken. So in history, we got something. Patient lifestyle. Patient lifestyle is like patient is eats chips daily. Many times he takes fast food chips. Is very fond of pickles. Very daily have fried foods. So patient lifestyle is not so good, and the salt intake is very high in patient. We noticed it. So generally, there is a definition of low normal high sodium intake varies according to the different studies, but as per WHO, reduced salt intake is less than 5 grams salt, and we overall generally we didn't calculate, but overall if we see the salt intake was even in routine diet also, his salt intake is more. So what we have done is we advise lifestyle changes and low salt diet we advise, and we asked him to review after 1 month. So next after 1 month there was the improvement in blood pressure we have found, and we have seen that DRC, although DRC then it came normal, and later on patient is not off tapered antihypertensive tapered, and patient is maintaining normal BP without any drugs. So in many cases we miss sometimes. These are a few cases false to error. These are very less common. Beta blocker one drug. Otherwise, NSAIDs and estrogen and ocipils usually only causes DRC changes, but don't affect much PRA. And sometimes in menstrual period, in luteal phase of menstrual period, also there will increase in aldosterone. Age will have effect. Sometimes CKD definitely will have, and depending on also the stage of CKD. And high dietary sodium may have decreased aldo and decreased renin, which is seen in our case, and also false negative. High renin seen in diabetics, ACARBs, and dietary CCBs have some effect. Usually CCBs have less effect, and the pregnancy low dietary intake also have increased renin and hypokalemia. As you know, we should avoid doing aldo DRC in hypokalemia because aldo will come low. So these are the few basic things we should see while doing routine cases. Thank you.
Thank you, Kiran sir, for your wonderful case presentations. The case presentation is now open for discussion. Nitin Kapoor sir, any inputs, sir?
Yeah, thank you, Dr. Kiran. That was a fantastic summary of your both cases. I just have a couple of points to add, but overall a great presentation. Very clearly explained all the concepts. For your first patient, 39-year-old gentleman, now got hypertension for the past 8 years, diagnosed at the age of 31. So one clinical important point would be that we should always look at the reports of these patients, which have been done previously. Hypertension for the first 7 years, and only last 2 years he presented to the emergency with accelerated hypertension. But many of the times these patients would have some kind of master is very important. The second point I wanted to highlight that the patient on ECG could be done, and that in clinical practice would tell us, okay, even if the patient alive and if he has
breaking our life. There's a break in our
Sir,
voice.
your voice is breaking, sir. Nitin, sir.
Sam got disconnected.
Yeah, I think he'll reconnect.
You can ask Suresh, sir.
Suresh, sir.
can you hear now?
Yeah, sir.
Right. So what I'm saying is that the first thing I mentioned was to go through the previous reports. The second thing I'm highlighting is that end organ damage history also has to be taken on examination as well. Looking for LVH, looking for retinopathy. Again, Dr. Kiran mentioned, but maybe the urine protein was not there. That is also something which is important to look at. So when you have a young hypertensive, looking at end organ damage is important. Regarding imaging and confirmatory tests, now with the newer imaging, better CTs, and now also with the availability of pentoxifer scan that we do at CMC Vellore now, our reliability is so good with the scan that our confirmatory tests, have come down significantly. Now there are specific types of PET scan which can be done for aldosterone producing tumors, and these are increasingly becoming available. They have a fairly good sensitivity and specificity. So that's another point I'd like to highlight. It was interesting that you mentioned about the co-secretion of cortisol, what is known as the Conching syndrome. Overall, the Conchings does have a slightly worse prognosis than Cons, but I think one point that I'd like to highlight here is you mentioned that the other adrenal, if it's normal, but one of the hints that we get in Conchings is that the other adrenal, if it's a unilateral cortisol producing tumor, the other adrenal will be atrophied. So if you see that, even on imaging, you can suspect that this patient has a co-secretion of cortisol and cons. So suppose you've proven cons and the other adrenal is looking thin or atrophied, even before biochemistry, you can think of Conchings. So having that contralateral adrenal looking not only for normal, not only for tumor, but even atrophy is really important. I think the management is very clear. You described all the scenarios, nothing more to add there. For your second patient, yes, lifestyle is important. The only odd thing I found was that the BMI of this patient was only 26, despite so much of unhealthy eating habits causing such high blood pressure. Probably the sodium intake, as you rightly mentioned, the salt intake was very high, but I think that is something important also to look at the BMI. That sometimes gives a hint. Maybe his body fat percentage would be high. And last point, I'll mention that sometimes patients are overzealous about restricting salt. Some of the elderly patients, they will say, "No, doctor, we don't want to eat any salt at all," and it will increase blood pressure, and they'll end up with hyponatremia. So I think a very right balance is required when people are overzealously worried about salt causing hypertension, and as in your case, where somebody is eating so much of sodium that the blood pressure is going up. But excellent presentation, and I think these are the only few points that I had. Over to you, Dr. Ashwini.
Thank you, sir.
Thank you, sir. Nice points.
Suresh, sir, can you please add anything, sir, to the case presentation? Any comments? Any inputs?
Okay, in the first case, if the patient had hypertension at 31 years of age with hypokalemia, then if there in that setting, if there is a unilateral adenoma more than 1 centimeter in size, because anybody below 35 years of age, then perhaps AVS is not required. But at that time, imaging was not done. So this is the correct thing only. But still, he had an episode at 31 years of age, which means that perhaps
Hypokalemia at 2 years back only, sir. Not
Uh-huh.
at 31. Hypokalemia only 2 years back. There isn't
Okay.
hypertension since that days, but hypokalemia, etc., since 2 years, it's last 2 years only is other symptoms. Sir.
And maybe the second point is that if you are having cortisol co-secretion and you remove the tumor, then of course the axis will be suppressed. So we'll have to add glucocorticoids till the axis recovers.
Yes, yes.
That's another minor point, but not minor, it's an important point. Then next one is the second case. When you are talking about hypertension with low renin and low aldosterone, then sometimes one of the common causes is actually one of the common causes is hyporeninemic hypoaldosteronism of diabetes. Some of them have hyperkalemia, and we think that adding fludrocortisone would be useful, but actually many of them are hypertensive. And in those cases, the way to eliminate the salt from there is some agent which is causing the salt accumulation. So using other diuretics like furosemide and all may help to not only correct the hypokalemia, but also correct the hypertension. So hyporeninemic hypoaldosteronism also comes in the low renin, low aldosterone group of hypertensive disorders. But in those patients, using a combination of ACE inhibitors or ARBs can cause hyperkalemia. Even beta blockers can cause hyperkalemia in the setting of mild renal failure with type 2 diabetes, that kind of setting. So that can be included in the, not in this patient, but in the differentials which are given on the table. Type 2 diabetes with hyporeninemic hypoaldosteronism also can be considered there. Okay.
Thank you, sir.
Thank you, sir. Thank you for your inputs. So there is one more question from Sandeep Julka, sir. For your first case at Kiran, sir, was ACTH done is what sir was asking. But ONDST is already suppressed, I think. Sir. It was
suppressed. OND is suppressed.
It was 1, if I remember. Okay. Then we'll go ahead with the second case presentation, sir. I invite Dr. C.H. Venkat Rakesh, who completed his DM endocrinology from Nellore Medical College and currently practicing at his center in Vijayawada, Sanjeevani Endocrinology Center. Over to you, Rakesh, sir, for presentation.
Good evening, morning, all. First of all, I would like to thank the entire Endocrine Society of EP team for giving me this opportunity. So today I will be presenting about pheochromocytomas, and we will discuss about the normal diagnostic dilemmas what we face, the therapeutic dilemmas what we face when we see a hypertensive patient, a young hypertensive patient, endocrine hypertensive patient, and when we are suspecting pheochromocytomas, what are the challenges we face. Is my voice audible and the presentation is visible?
Yeah, it's safe. Only full screen mode is required. The rest is fine.
No.
Full screen now. Slides are visible, but in full screen.
No.
You're sharing the screen, sir, but slides have to come yet. Your screen is being shared, but slides are not.
Is it visible now?
Yeah, sir. Yes. Now you can go to the, we can see your folder, sir, the PC data. Maybe you should open it once.
My screen it is. No?
Okay. You double click the PPT, it will open and share.
Sir, after clicking on share button and click on entire screen, not any folder. Just you click on enter skin.
Share on entire screen.
Please click on share button.
Okay.
Make it into power. Excellent. Same. Yeah, perfect.
It's fine, sir.
Okay. So thanks to Kiran. So one of the case is Kiran's case, and this case even Murli sir knows because we discussed about what to do about this case. So this she is a 75-year-old female who was found to have bilateral adrenal instant Actually, she was being evaluated for dyspepsia by a gastroenterologist, and they did an ultrasound, and that was suspecting, and then they did the CACT. She is non-diabetic but hypertensive, but she is well controlled on calcium channel blockers. So they have done CCT in view of ultrasound findings, and CCT abdomen it showed left adrenal there is an irregular nodular enlargement of the left adrenal gland, and the size of the nodule was 2.1 into 1.6 centimeters. In the right adrenal, the body and limbs of the right adrenal were thickened, body of the size of 10 mm and the limbs of about 5.4 mm. So here is the case of non-enhanced CT, where the right adrenal, the limbs are thickened, whereas the left adrenal, there's an irregular or inhomogeneous enlargement of the nodule. And this is the venous phase, early venous phase, and this is the delayed venous phase. What suspected in this imaging of suspicion of pheochromocytoma is the enhancement, diffuse or very high enhancement in the arterial phase and the venous phase. And then if you see that HOs here in plain CT unenhanced imaging, the HO was 19 for right adrenal and left adrenal it is 20, definitely more than 10. And the enhanced venous phase is almost all 112, and which is not, which is very unusual for a simple adrenal adenoma. So the absolute washout percentage, if we calculated for this patient, it was close to 60% for the right adrenal, and left adrenal it was 64%, and the relative washout was 49 and 56 for the adrenal. So again, this is satisfying our criteria of 60% and 40% of absolute and the relative washouts. But the typical features of adenoma are again lacking. So it was actually the not routine protocol what we followed, because imaging was done elsewhere, and then because of in view of suspicion of this imaging, it was referred. So CCT, the final diagnosis given was lipid poor adenoma. So 24-hour urinary metanephrin was done. Metanephrins were 574 microgram per 24 hours, and the normetanephrins were 878 microgram per 24 hours. This was not. This was very close to our limits of 900 and 400. Again, plasma-free metanephrins were done, which were absolutely normal. So then, in view of suspicion of that imaging, since it is an adrenal incidentoma, probably it might also be a pheochromocytoma diagnosed at the very earlier stage, but it is an asymptomatic. And these days, we see many adrenal incidentlomas or pheochromocytomas diagnosed in the form of adrenal incidentlomas because of extensive imaging for various other reasons. So she was also undergone gallium dot PET CT, which was showing an intensely heterogeneously enhancing nodular lesions in the bilateral adrenals, with the left adrenal showing 2.1 into 2.1 centimeters, and the right adrenal it is a diffuse enhancement. There are no other lesions. And based on PET imaging, the definitions were either pheochromocytoma or adenomas, which were lipid poor. This is case 1. And coming to case 2, this is the other extreme of case where this is a classical pheochromocytoma, again, the diagnosed as adrenal incidentoloma in the evolution of adrenal incidentoloma, but there is a clear-cut elevation of metanephrins and normetanephrins. But in the imaging, we will see what challenges we faced. So case 2, 60-year-old male, known case of type 2 diabetes and hypertension, and again, right adrenal mass. And he was on telmisartan and amlodipine, and the blood pressure was not that well controlled. CCT was showing hypotension in the right adrenal, 4.6 into 2.9 and 3.3 centimeters. and there is a focal subpleural nodule noted in the posterior basal segment of the left lower lobe. This is the initial CCT report. This was not exactly that image, but the washouts, if we see, the unenhanced H2 was 45. Again, classifying our criteria of more than 10. Enhanced was 79, and delayed portal venous phase was 52. Absolute washout was 79, definitely more than 60%, but relative washout was 34%. So less than 40%. In biochemical imaging, biochemical values, the plasma-free metanephrines, which were done by ELISA method, and metanephrines were 363 and normetanephrines were 6,661. And FDG PET scan was done. Again, this entire evaluation was done at an oncology center, and after doing the FDG PET, it was referred to the endocrinologist. So FDG PET, it was done, and FDG PET was showing non-FDG avid solid intrapulmonary nodules in the bilateral lungs, which was the largest nodule was in the posterior basal segment of the left lung lower lobe, which was about 1.2 centimeters. So they could not comment upon this because it's just non-FDG avid. And in the right adrenal gland, non-FDG avid enhancing lesion corresponding to a right adrenal pheochromocytoma was noted. And they advised a Dotnak PET to further characterize the lesions. So it's a simple right adrenal lesion, but there's suspicious lesions in the left lung lower lobe. So pre-op, he was managed with alpha and beta blocker. There's no hypertensive crisis during the entire episode, and robotic right adrenalectomy was done. So histopathology was showing paraganglioma and pheochromocytoma. The 6 centimeters was the lesion size, which was largest in the largest dimension. So again, over a period of follow-up, after the resection of right adrenal adenoma, the hypertension was well controlled. But in the follow-up, when we did the repeat metanephrines were done, the plasma-free metanephrines by LCMS method again repeated twice, which was showing elevated normetanephrines. The metanephrines were normalized, but the normetanephrines were still very high, and methoxytyramine was normal. So this time, again, gallium dotonic PET CT was done, but because in the FTG PET initially there was not such information which was done earlier. So probably this could have been done in the earlier stage in the first instance. So the gallium dotonic PET CT was showing a tracer avid renal hilar lymph node or lesion along the right renal vein. Just adjacent to the place of surgery, there was a small lesion. And there were a few more lesions, and which were tracer avid and in the intrapulmonary nodules, which are noted in the bilateral lungs, and the posterior basal segment of left lung lower lobe. If you see the previous FDG PET prior to that operation, this was coinciding with this lesion, which was done, which was diagnosed in Dotnak PET CT, which was done a year later of surgery. So probably this could have been done in the earlier stages, which we would be confirming that this is a metastatic lesion and not a single lesion. So these are the two lesions which were identified. One was close to the surgical site, and one was one more lesion was that image I don't have. One more lesion was in the left lung lower lobe. So the diagnosis of this PET imaging, the Dotnak PET imaging, was it was an FSTR expressing lymph node along the lesion along the right renal vein, and SSTR expressing intrapulmonary nodules in the bilateral lungs. And compared to FDG PET, there was no further, which was done a year back, there was no increase in the size. So, and it is a metastatic lesion. Again, now since the primary lesion is improved, so what is the plan of this patient post this metastatic lesion is one question. So what could have been done in this patient, or what are the questions or dilemmas what were arised in these two cases where or routine when we evaluate an adrenal instantiloma for suspecting pheochromocytoma, what are the challenges we face where what test do we do? At the first instance, what test do we do? Whether it is plasma metanephrines or 24-hour urinary metanephrines, which test should be done? And what are the cutoffs for diagnosing pheochromocytoma? What I mean is when we do plasma metanephrines, whether it is 2 times or 3 times elevated of the upper limit of the normal, and when we're doing 24-hour urinary metanephrines, what cutoffs we take for diagnosing? because in the first case, the values were almost all close. The 24-hour urinary metanephrin were 900 and 400 cutoffs were very close, but the plasma metanephrin were absolutely normal. And whenever you're sampling this, these patients for metanephrines, whether it is 24-hour urinary or plasma fractionated metanephrines, so what are the drugs to be stopped? That is one more question what we face. And in the preoperative control of these patients, why? Because it's very difficult the patient to be admitted and do an alpha and beta blockade sequentially. Rather than that, can we use a calcium channel blocker? Because calcium channel blocker was also shown to be very effective in controlling the hypertension in these patients and preventing the preoperative hypertensive crisis in these patients. And coming to imaging, what is the advantage of MRI, or when do we advise MRI in these patients? And next, coming to nuclear imaging, what is the role of MIBG? MIBG scanning was being done frequently a few years back, but now the newer modalities like dot-knock PET or dot-tate PET is being done because of their SSTR recognition of the nodules and better recognition of the metastatic lesions at the earlier stages. And in coming to PET-CT, we have FDG PET, we have dot-knock PET, and we have DOPA PET. So the availability of these PET scans at that particular center is definitely very important. And FDOPA PET, yes, it is very, it is the most accurate PET-CT in diagnosing these pheochromocytomas, particularly when they are intra-abdominal in location. And but the cost of this scan is very high and is not readily available. So we would prefer to use a dot-knock PET. Again, this availability is not at all the centers, at all the tertiary, at all the centers over the India. There are few PET centers doing this, at least in the peripheries. So again, we prefer to use, because of cost and because of availability, we would go with dot-knock PET CT scan. Again, dot-knock and dot-tate, there is not much difference, but what it was said is dot-tate PET, it is expresses or it screens only for SSTR2, whereas dot-knock PET, it screens for SSTR2, 3, and 5, so which has a wider availability in diagnosing or detecting the metastatic lesions or multiple lesions. Coming to FDG PET, as we have seen in this case, FDG PET, as it is mainly useful for diagnosing the metastatic lesions. So when the lesion is well differentiated lesion, which secretes normetanephrines and metanephrines, which expresses SSTR, probably dot-knock PET is better. And when the lesion has already metastatized to the liver or to the bone mets, and in such cases where they de-differentiate or they do not express the SSTR, in such cases FDG-avid lesions may be diagnosed. So in particularly recognizing these lesions, at first instance, probably we can go with dot-knock PET. Again, in dot-knock PET, if you see the pheochromocytoma classifications, we have cluster 1 and cluster 2. Cluster 1 mutations, when there are SDH mutations, succinate dehydrogenase mutations, they're de-differentiated or poorly differentiated lesions, and they have high chance of metastasis. So in such cases, probably we might the FDG PET might be more useful. Whereas in cluster 2 mutations, where there are differentiated lesions, where they express SSTRs for 2, 3, or 5, in such cases, dot-knock PET is very useful. So again, sometimes we might have to do both the PET CT scans in further coming to the conclusion, because when there is a metastatic lesion, the nuclear therapy might be more feasible than the surgical therapy. But it is a localized lesion or a single lesion or dual lesions which are resectable. In such cases, the surgical modality is useful. But when it is diffusely metastasis, the entire management protocol changes. In this case of asymptomatic pheo, where it was actually an retinal incidentoloma diagnosed by biochemical imaging, what is the best treatment of a plan? So whether should be just wait and watch, because in these patients, when we give them the diagnosis of a pheo, but and you already have an pheo, and we just wait and watch, should we place the diagnosis, or even though it is an asymptomatic, should we go for operated, because, or should we go for operation, because in the later stages, what is the chance of this pheo becoming symptomatic? There is one diagnostic dilemma what we face. So I want the panel members to discuss about these points.
Nicely presented, sir, and the clinical dilemmas which we face. So the forum is open for discussion. Nitin sir, regarding the first case, sir was asking the asymptomatic elderly 76-year-old lady with bilateral pheochromocytomas, whether it was diagnosed early and can we wait and watch or go for a bilateral enterectomy, and whether we have to evaluate for other cortisol and other axes, whether those as well.
Right. So very interesting cases. Paradoxically, both the patients you presented were relatively older. Usually in clinical practice, we'll have pheochromocytomas at a younger age. From CMC, I can say that our mean age would be in 30s. But yes, sometimes we do encounter these patients in old age. I think the first point I'd like to highlight here is that when you have an adrenal lesion which has been diagnosed before biochemical imaging or biochemical testing, I would say that as the patient becomes older, the prevalence of adrenal incidentallomas increase. So in seventh decade, they would say 10% of the normal population would have an adrenal lesion. So I think that we have to keep in mind very well, because if 1 in 10, just by doing a scan, is going to have an adrenal adenoma, we have to make sure our biochemistry is so robust that it makes sure that it rules out these age-related adrenal adenomas, which are incidental and have nothing to do as compared to the pheochromocytoma and other problems. I mean, overall, well presented. Talking about metanephrine in the urine versus the plasma values, we at Vellore have stuck on to urine 24-hour metanephrines. There is very good data from KEM suggesting that plasma catecholamines are really good, higher sensitivity and specificity. The only downside of plasma is that sometimes these hormones are intermittently secreted. So if they are not secreted at all times in the day, the 24-hour urine would still pick it up, but not a blood sample at a time point. But definitely with neoassays, the plasma is equally good. We at Vellore do not do plasma at all. We do urine. This was an interesting study I posted in the group by Dr. Kanagmani, who had done her DM from AIIMS Delhi and then worked with us in Vellore before moving on to Australia. She was with us for a couple of years. And this was an interesting study which showed that, if the urine metanephrine and non-metanephrine have to be significant, their value should be 2 times the upper limit of normal of the given assay that you're using. So very important that borderline values are not always helpful. 2 times upper limit of normal is what is expected for it to be significant. You talked about imaging, which was interesting. We at Vellore still depend lots on MIBG. We have the PET scans, the DOTA, the FDG, but MIBG is cheap. The cost is, I would say, 1/4 of or 1/5 of a DOTA PET scan here in Vellore. So it's not widely available, but we still depend on it for some patients. Over the years, we've got really a huge repository of how good MIBG has been. The only problem with MIBG, especially if you've had somebody like a metastatic case like you had in the second one, so if there's a large lesion with a pheochromocytoma in the adrenal and the metastases are small, when you do the MIBG at baseline, the large lesion will take all the dye and the metastasis will show negative and you may miss it. So sometimes, if you're suspecting small satellite lesions, MIBG may be helpful at a later stage. After the surgery, you remove the big lesion, and then when you have to target and identify the small lesions, it may be helpful. Nevertheless, obviously, if it's metastasis, FDG would be better than MIBG. Talking about blockage before surgery, alpha blockade versus calcium channel blockers. Calcium channel blockers still, at least in Vellore, we still keep it as second line of choice. All our patients do get alpha blockade, but there is a a Swedish group, which does only calcium channel blockers, and they have good results. They publish their papers, and we somehow discussed it many times with our endocrine surgery colleagues, but we have decided to stick on to our convention, and we give alpha blockade first. Only once the patient develops adequate tachycardia, they are well hydrated, or after about 8 to 10 days do we start beta blockers. So we don't usually do MRIs. We do CT scan, contrast CT, and that is usually well enough. If required, we think of an MIBG, especially in a younger patient where we are suspecting we have two-sided lesions. We want to know which side is pheo, which is not. There, it is helpful. Now, I think one important point when we discuss pheochromocytoma that we should also cover is the important role of genetics. Not in these two patients that you suggested, these are two older patients, but in younger generation, I think it's very important. Again, data that we published from Velo, we found that about 35% of pheochromocytomas that we have seen had an underlying genetic mutation. It doesn't really help for that given patient. You may be able to find out the associations, if it's VHL positive, but really very helpful to identify the family members who may be absolutely asymptomatic. And that's where I think this is helpful. And now with the newer, facilities which are available with NGS, the cost isn't that much, 8 to 10,000 rupees. You can screen for the common genes, and they have a stepwise pattern. So this is what I would say. Are the few comments from my side. Definitely, I would not leave a pheochromocytoma, untouched after diagnosing. I remember Sheshadri sir, when the student would say this is like a time bomb and it can explode at any point in time. So I wouldn't really, have the guts to say that, okay, pheochromocytoma, you just wait and watch. But yes, if the patient is really old and has more morbidity and mortality because of the age and comorbidities, then it would be a discussed decision with the family to come to a consensus. But by and large, we would try and stabilize and offer surgical removal for most patients. So that's from my side. Over to you. But great presentation, Dr. Rakesh.
Thanks.
Thank you, sir. Rakesh sir, there is a question from Golla Kiran sir. Like in the first case, what was the method used for that metanephrin and non-metanephrin, whether it is LCMS or
no, the first was not LCMS. It was ELISA method done somewhere else. It was not LCMS.
Okay, thanks. Then, Suresh sir, regarding the second case sir has presented, how would you go about that case of metastatic pheo, sir? How will we proceed further? The patient already underwent.
Ashwini ma'am, Kiran was asking about the first case.
Yeah, that was, yes, the first case, the doubt was whether
metanephrin. Yes.
Yeah, metanephrin. You told whether it was ELISA or LCMS. You have told that it was ELISA.
No. The urinary metanephrines, so the first case, the urinary metanephrines were HPLC method and the plasma metanephrins were LCMS method.
Yes. Okay. Yeah. Fine, sir. Thank you. And Suresh sir, regarding the management of the second case, how would you go about it, sir? There was a pheo which is metastatic. Patient already underwent adrenalectomy and further had some remnants remaining, relatively around 60 years of age. How to proceed further? And gallium dotanox still showed some remnant after the surgery, and normetanephrines are still elevated.
Okay, first thing is that before doing any kind of ablative procedure, including chemotherapy or even embolization or anything you want to do, first you have to do the full alpha blockade, because any damage to the lesion will naturally result in release of stored this thing. So you have to give the full alpha blockade, and if there's tachycardia, give the beta blockade also. Then second question is there are many methods to tackle the residual lesion. For example, in the lungs, it was there. So one is find out the feeding artery and embolize it with gel foam. Or if it's a very small lesion close to the pleura, then radiofrequency ablation or cryosurgery, that kind of thing can be done. And chemotherapy, combination chemotherapy is also there, but success rates are like 20-30% only. But again, you have to do the full alpha blockade. Then lutetium dotatalk can also be given. So because if it's already taking up gallium 68, so it is naturally having somatostatin receptors. So it should be able to stabilize the lesion for some time using that lutetium. I think this is all that I can think about. But one more thing is that these people will require prolonged alpha blockade. So better to use the non-selective like prazosin or doxazosine, which are more comfortable for use rather than phenoxybenzamine, which will produce a lot of side effects. So on long-term basis, they'll have to receive alpha blockade. That's all I can think about.
Okay, sir. Thank you, sir.
Anything else somebody can suggest? Maybe resurgery can also be done for the lymph nodes which are in that bed, but not for the lungs.
Yes.
Basically, sir, actually, that patient first diagnosis was incidental finding. He, from the starting, fever itself diagnosed some incidentally. Surgery was done, again, meds incidentally. Patient is means fed up that I am not having any symptoms. Why you are doing so many things? So actually, for this also, even metastatic fever also we can classify into 3 grades. Depending on the rapidity of the progress, also treatment may change because if it is rapidly progressing, we can even prescribe chemo. If it is moderately or slow progressing, few cases wait and watch also can be done, and few cases, as you suggested, PRRT or MMVG therapy can be done. This patient I actually because of risk of family members, I suggested genetics also and planned discussed regarding further mind, but he is actually right now not much interested. So right now he's under just follow up. He is on prazosin, BP is controlled. So right now under follow ups. That's all.
The problem with these incident lomas is when they're not diagnosed, okay, sir, but when we diagnose and keep one diagnosis on that name, what happens? Again, wait and watch is big problem.
Another problem is if these people require emergency surgery for any reason. They have developed appendicitis or road traffic accident or something. Anything can happen during the anesthetic procedure, even if they are currently asymptomatic.
Yes, sir.
Yes. As sir said, it's a time bomb that can explode at any time, which the patient doesn't realize.
But if it is a bilateral lesion and is completely asymptomatic, then and his patient is 70, 80 years old, then I think it is better to leave it, because a bilateral lesion means you have to remove both sides and then you have to give all your cortisol and hydrocortisone and fludrocortisone. That is a really painful procedure and associated with mortality also.
Yes, sir. Considering her age, probably
we can.
Unless the surgeon can do a cortical sparing.
Adrenalectomy, cortical sparing surgery. Yes. And there is one more question from the audience regarding discontinuation of antihypertensives before testing for ARR for primary hyperaldosteronism. Any protocol to be followed?
I think we have to stop spironolactone and eplerenone for 6 weeks, and telmisartan and AC inhibitors for 2 weeks, and beta blocker also. And you can put the patient on calcium channel blocker and alpha blocker safely. Valsartan also, not valsartan, sorry.
Moxanidine also can be.
Moxanidine. Yeah.
Okay. Yeah. So that ends the audience questions also. Any more questions from anyone? They can post in the chat.
Ma'am, I want to just ask that regarding the aldosterone case. So previously we were thinking that there were criteria for evaluation of for evaluating an resistant hypertension from suspicion of aldosterone adenoma. But now the changed line is that every patient with hypertension, irrespective of the criteria, should be evaluated at least once in their lifetime for aldosterone adenoma. That means DRC and PAC should be done for every patient of hypertension.
Suresh sir, can you
that if at all, it is a bit difficult, because most of the times now, if you want to evaluate, you have to evaluate in the very beginning, not after starting medication. Most of the times we start telmisartan or something like that. If you start calcium channel blockers, you can still evaluate, but I think that is a little bit of too much for 10% yield, or maybe even less. And another thing is, there is this condition which is called idiopathic hyperaldosteronism. So when you look at idiopathic hyperaldosteronism, you do histopathology of the adrenals, you don't find anything there. It is a purely functional state. So how did they come to, when you have a gold standard, for adenoma, the gold standard is histopathology. It is there in your hand. But what is the criteria they used for idiopathic hyperaldosteronism? There's no lesion. There's no lesion on even electron microscopy in the adrenal. So they have just used the same aldosterone cutoff and the same plasminogen cutoff which they developed for adenoma. So is it a real condition? I have some doubts about that, because when you do anything in the adrenal gland, histopathology, electron microscopy, you don't find anything there. So those cases, what's the point of finding out whether aldosterone is the cause or not? In those cases, you can treat the hypertension, and then if it is resistant, you can add spironolactone. Of course, the argument will be that if you don't tackle it from the aldosterone angle, you will get more left ventricular hypertrophy, more CKD, and more stroke. But has that really been proven? That is all for the adenomas only that thing has been proven. For the idiopathic hyperaldosteronism, it is truly idiopathic. This only by definition it is hyperaldosteronism. By definition, where you are using the same cutoffs which you developed for the adenoma, where there is no lesion at all. So I think it's a little bit of a hyperbole. And when you look at the, they say that 4 to 10% of hypertensives are having aldosteronism. One quarter of that, or about 30% of that, is adenoma. 70% is hyperplasia. So this 70% which you can deal with as any other antihypertensive drug, whether really spironolactone works there. Spironolactone itself causes gynecomastia and causes erectile dysfunction or mastalgia in women. So with all those things, whether you really want to treat with spironolactone, that is, I don't know whether everybody needs workup or not. Definitely the people with higher BP, hypokalemia, or adrenal incidental lesion, those kind of, or as you said, hypertension below 40 years, or a young hypertension with a stroke, those things, those cases definitely you should treat. But if you want to investigate in the beginning, not after starting treatment.
Yes, probably our clinical judgment here makes the difference. Whom to evaluate to make it cost effective.
Right, and also it depends on where the patient is being seen. There was one interesting study looking at a patient being evaluated at a primary care versus at a quaternary care. So the number of patients with primary hyperaldosteronism would be much more in a referral center where the patient has already been treated by several doctors and then reached there. So maybe at institute level you may consider to do it for more people, but primary care your yield will be very low, as rightly Suresh sir mentioned.
Sir, Nitin sir, previously we were discussing about the cutoffs for the diagnosis of metanephrine for pheochromocytoma. It is 2 times the upper limit of both urine and the plasma. Both holds good.
No, the study is mainly for urine, not for plasma. Plasma, they say the absolute cutoff.
Yes. It's a wonderful discussion, sir. So if there are no more questions, we can wind up the session then.
Thank you, Dr. Ashwini, for the explanation.
Thanks a lot, sir. Thanks.
To both presenters as well as for your wonderful discussion, Nitin sir and Suresh sir. Thank you all the audience also for your active participation.
Thanks, sir.
Thank you.
Thanks, Thanks, Nitin sir.
Have a good night.
Bye-bye.
Bye.